Okay, so in this video we will review transitional cell carcinoma of bladder. The transitional cell carcinoma of bladder is the most common type of bladder cancer, which accounts for almost 90% of all bladder cancer. It is more common in men and its peak in their 6 to 8 decade of life. The primary risk factor of transitional carcinoma is smoking, which is the strongest association. Other risk factors include occupational exposure to aromatic amines, which includes dye, rubber, and leather industries. Chronic bladder irritation from recurrent UTIs and prolonged use of catheter is also a risk factor for transitional cell carcinoma. Apart from this, cyclophosphamide, which is a chemotherapy drug, and radiation exposure also increase the risk of transitional cell carcinoma. Moving to its clinical features, the most common symptom of transitional cell carcinoma is painless hematuria, which means blood in urine, which is often gross, which means the blood is visible. Other symptoms include irritative voiding symptoms, which includes frequency, urgency, and dysuria, which means painful urination. In advanced case, flank pain may occur due to hydronephrosis, which is swelling of kidney due to ureteral obstruction. Now, in order to diagnose, imaging is used, and ultrasound is often initially to detect any mass in bladder, and then we move to CT urogram, which is the gold standard for evaluating both the bladder and upper urinary tract like kidneys and ureter. Then cystoscopy with the biopsy is used for definitive diagnostic tool because it's allow for direct visualization of bladder and biopsy of any suspicion lesion for confirmation. Now to stage we use TNM classification, and if the transitional cell carcinoma where tumor is confined to mucosa and some mucosa, then it is graded as TAT1, and if it invades the bladder muscle, then it comes as T2. Now in order to management in order to manage the carcinoma, we either use transitional transurethral resection of bladder tumor, intravesical therapy for non-muscle invasive tumors, and for muscle invasive tumor we use radical cystectomy, and in some patients we go for bladder sparing therapy along with chemotherapy for metastatic disease. The prognosis is good for non-muscle invasive tumors, but for muscle invasive tumors it is worse, and it also depends on stage. Okay, the early detection by cytoscopy. Now, this is the key point that early detection by cytoscopy is key for especially high risk patient. Cytoscopy with biopsy is definitely diagnostic tool, and this brings end to our lecture.